very good evening to one and all of you. And thank you very much, Youthful IRSI, for including me in this session. And thanks, Dr. Himanshu, too. So going on to my talk, clinical signs and symptoms. My opponent did talk very well, but what we see is a parched ground. But believe me, friends, dry eye is not as gross as what we are seeing. It is neither is it that it is so buried, it is disappeared, it's evanescent that we are not able to diagnose it, that we need to resort to these exotic equipments. Frankly, dry eye is a disease. If you can't explain it simply, it just means that you have not understood it well enough. Just a minute. So I think it's the most intelligent thing when we're treating dry eye is to just draw a straight line joining two dots and not go winding and winding in circles. Keeping it simple is what the mantra is. I don't know what's happened. It's not moving. Just a minute. Why is it not moving? Sorry, I'm very sorry. So, can somebody tell me what went wrong? Not able to.
Ma'am, maybe you can click the arrow at the bottom left.
Yeah. So what I'm trying to convey is, for something as simple as a dry eye disease, complex diagnostic procedures are actually not required. Yes, it is required. If your trip in life is something very commercial, something dry eye disease has just become an incidental issue with you, and truly, this is not the roadmap for dry eye management. Honestly, you can be powerful without being loud and aggressive. And I just cannot fathom why you need to crush your skills and bury yourself when all that you're facing is dry eye, which is actually a general practitioner's game. So I don't know, friends, do I simplify the complex or do I just keep it as simple as what this disease requires? Because when the mind stops to perceive everything, where the mind loses its common sense to treat the simple, I think the mind has lost it all. Let's understand that human mind, especially us medicos or the doctors, as we've evolved, we've gone through a laborious training. We have tried to understand diseases in entirety. We've tried to analyze it. We have tried to differentiate it with differential diagnosis. We have tried to use research clinical trials to bolster it, but not trigger the madness of trivialities made complex. So let's get to the definitions first. Dry eye is a multifactorial disease characterized by persistently unstable or a deficient tear film causing discomfort or a visual impairment accompanied by varying degrees of ocular surface epitheliopathy, inflammation, and neurosensory abnormalities. So let's break this talk into pieces of simple jigsaw puzzle. The symptoms could be any one of this in isolation or could be all of them or part of them. But then symptomatology is so simplistic and so mundane, my friends. So you need to do a root cause analysis. Does this patient have an unstable tear film? Then do you anticipate tear hyperosmolality, inflammation, a consequent epithelial breakdown, which is going to expose and irritate the nociceptive receptors, and that causes discomfort. An unstable tear film could disturb the optical property of the tear film, and that could be the cause of visual blur. So you could have any of these symptoms, but based on the symptoms, not the signs yet, you could have actually treated the disease. But going further, you go and check the vision of the eye, and that between blinks, the vision clears up. There's a minimal drop in contrast, there's ptosis, but then you don't go and investigate for myasthenia. Do a slit lamp examination of his lid margins, the excoriations, the meibomian glands, the pouting glands, the thickened lid, those inflammatory signs, those telangiectatic vessels around the meibomian glands, the matting of the lashes. There could be coexistent allergic manifestation, which could probably make it a little more complex. You look at the ocular surface for SPKs, erosions, filaments, conjunctival congestion, mucus flakes, dry eyes, xerosis of conjunctiva. Everything's there, right there in front of you. So you've diagnosed it actually, but then you have to have some basic tests. So you do a Schirmer's, you could do a tear breakup time, you could look at the tear meniscus height, you could do a fluorescein stain, you could do a rose bengal or Lissamin stain, but that tells you all. So the key criterion is the tear film instability. And we have basic sensitive measures to judge the tear film dysfunction, easily measure it. It's clinically practical. And believe me, it's as reproducible, if not better, than all those gadgets which we heard of. So what do the patterns say? A tear film breakup pattern would tell you whether we are looking at an aqueous deficiency tear eye, or is there something wrong with the lipid layer, and then if there's something wrong in the surface epithelium, and then you go on to subclassify the dry eye and then select the appropriate therapy, as Anagha beautifully explained. So if you look at the fluorescein pattern, you could have in aqueous deficiency dry eye, you could have an area break, you could have a line break, you could have a decreased wettable dry eye, you could have spot breaks, you could have a dimple mark. In an evaporative dry eye, you could have something like those random breaks, you could have that random breaks with expansion, all typical examples which keep telling you that you're looking at aqueous deficiency, you're looking at decreased wettability, and actually majority of the eyes, it's evaporative dry eye which you're dealing. We need to look at the epitheliopathy if if there's a corneal disease, you could fluorescein stain it. It will give you enough and more information, and you could grade the kind of disease which you're handling. A conjunctival disease, if there's a goblet cell loss, if it's minimal, maybe a little difficult to pick up, but more this conjunctival staining and the tear breakup time being deficient, you already have your diagnosis. Inflammatory markers, yes, but what is the big deal of knowing about each specific inflammation? You know that a dry eye could have an inflammatory sign, and there are some glaring signs. Look at the meibomian glands, look at the conjunctiva, look at those telltale telangiectatic vessels on the lid margins. You see it all. You can evert the lid, you can see those meibomian glands. So everything is there, and basically, finally, if there is inflammation, you're going to treat them with soft drops. You're going to treat them if with cyclosporin. If the need is indicated, you would not use punctal plugs in these eyes. Why is it that ocular surface index was identified? Because it was understood that this is one disease where the symptoms and the varying symptoms would help you grade the disease as normal, mild, moderate. Friends, listen to your patient. They may have everything which you need. Yes, to get to a better diagnosis, as said, symptoms alone get you there, but the symptoms and signs, and sometimes there could be a discrepancy. So you need to evaluate them, no doubt, because there could be a situation where the severe epithelial breakdown, inflammation, and long-standing dry eye, it could be neurotropic and the patient may not complain. And there could be a patient, as one of my earlier speakers said, where there is no visible sign, but he has that neuralgic pain, and then it indicates that you do a tear breakup time, and in his case. There could be visual impairment, and recent studies tell us that an unstable tear film, we could have an increased accommodative microfluctuations and accommodative spasm, which puts a greater burden on the ciliary muscle. We could have a functional visual acuity deficit, which could be something real-time functional ability of the visual perception. Some patients may find, but at the end of the day, the dryness is more, or people who keep looking at the monitors, if they have an uneven tear surface, the blue light scattering is more. So you wear appropriate glasses to deal with it. So essentially, with the signs and with the symptoms and with your intelligent mind, you could sum up the diagnosis, and there is the management. I often feel that a smarter mother makes often a better diagnosis than a poor doctor. But then I have to tell Pooja too that ASOCT has come in, but there are conflicting reports of the sensitivity and specificity when it comes to measuring the tear meniscus height and tear meniscus area. I can't understand why we need to do an ASOCT for this. Maybe you have the gadget for other diagnosis. You could just supplement it there and do an analysis on it, because it's not going to help you, and it's not even a reliable measure in severe conjunctivocalysis. Again, a non-invasive tear breakup time, topography in between two topographers, that measure is not right. So let's be pragmatic and realistic, friends. Certain diseases cannot be diagnosed. Certain diseases are hidden and rampant, and we are not so latent that we need conclusive imagery there. But dry eye disease can survive an ideal management strategy in spite of the still evolving good imagery with its vagaries. So why would I recourse to advanced diagnosis when my history and signs are conclusive? Would it make me miss something critical and grave? Would it enhance a better treatment of the disease when the diagnosis is already made? Maybe it would enhance better reporting and documentation. I think it's meaningless to be busy and being unproductive. Why would I increase my chair time? Probably the economics would go up, but would it not translate to a happier if the patient is rapidly disposed and feeling of being less cheated and greater gratification and a greater footfall of future happiest patients with trust and confidence? Does business of ophthalmology mean that you start doing money minting at every twist and turn? Does it justify that you start over-examining a common cold and a running nose? Would you question your basic intuition and clinical sense? Have you set yourself on a trail of lost skills, not just about robotic surgeries, but a robotic mental prowess? We do need these equipments, no doubt, but the magnitude of the disease and the diagnostic challenges alone justify a recourse to a panel of investigations. A complex jigsaw puzzle is not created to make simple learning more complex, my friends. So let's allow ourselves to treat a simple disease as it exists. Allow your time to learn to treat more complex diseases, sharpen your intellect, allow your mind to stay challenged and right. But please escape the treacherous hands of industry and mad economics. Coronavirus crisis should teach us better about life and its values, and that physician in you, my friends, should never die before you're dead. Thank you.